So the next section we're going to talk about the two subtypes of autonomic receptors based on what they're activated with. Cholinergics are the one with acetylcholine and adrenergic with adrenaline. So let's start with cholinergic receptor. Acetylcholine is the neurotransmitter for this type of receptor, and there are three distinct classes of these receptors that we talk about. It mediates the first messenger function of the transmitting impulses within the parasympathetic nervous system. Remember, the preganglionic and postganglionic for parasympathetic was acetylcholine. The ganglia of the sympathetic nervous system has the acetylcholine as a neurotransmitter. And also the neuroeffector junction of striated voluntary muscles. Cholinergic receptors are divided into two categories based on activation by nicotine and muscarinic, so muscarinic and nicotinic. So let's talk about the first grouping of the muscarinic receptors, and they're grouped together in 1, 3, and 5 because when you activate them and acetylcholine binds to the receptor, it results in activation of G protein coupled receptor subtype Q, so GQ. When you activate GQ, you get stimulation of the phospholipase C pathway, so this results in increased IP3 and DAG, and then you get protein kinase C activation as well as intracellular calcium concentration going up. So this results in a response because calcium is a wonderful molecule that can be used for signaling pathway because there's such a big difference between intracellular and extracellular concentration. And the concentration intracellularly is so low that when you have a rapid influx of calcium, even a little bit of it, it's going to be very quickly detected, so that's why it works well as a signaling molecule. Now, the other subtypes M2 and M4, when acetylcholine binds to the receptor, it results in activation of the inhibitory G protein, so GI. So when GI gets activated, you have inhibition of adenylate cyclase, and also activation of the potassium channels, which results in increasing outward flow of potassium. So this hyperpolarizes the cell. And also, when you inhibit adenylate cyclase, your CAMP concentration will go down. So CAMP, if it gets up, it activates the pKa and modulation of channels and signaling pathway, but now we inhibit that. Now, when we stimulate the muscarinic receptors, the kind of symptoms you see, the signs are bradycardia, decreased inotropism, bronchoconstriction, meiosis, saliva, GI hypermotility, or increased gastric acid secretion. So, lots of effect. So this is what neostigmine does. And the way neostigmine works is it interferes with the breakdown of acetylcholine. So it indirectly stimulates both the nicotinic and muscarinic receptors. Well, you can block this muscarinic receptor by atropine without affecting the nicotinic receptor, because atropine is a competitive antagonist of only the muscarinic acetylcholine receptor, not the nicotinic. That's why, glycopyrrolate, the same thing. Glycopyrrolate and neostigmine are such a good combination, or not a good combination, I should say, but such an adequate combination in terms of blocking, in terms of reversing your neuromuscular blockade, because you don't want to affect the nicotinic receptors. Now, here we're going to talk about the postganglionic nerve, and you have to keep in mind and try to keep track of it so you don't get confused with postganglionic, postsynaptic, and I'll try to use diagrams to help you not get confused. So postganglionic nerve is the one that comes from the ganglia and goes to the organ. So now they're found in the presynaptic terminal or membrane of the sympathetic nerve terminals, in the myocardium, coronary vessels, and peripheral vasculature. So these muscarinic receptors, now we're talking about the presynaptic membrane of the postganglionic nerve. can see it right there. When you stimulate them, they inhibit release of norepinephrine. So they inhibit the excitatory neurotransmitter. When you block it, it removes the inhibition of norepinephrine release, so it acts as augmenting sympathetic nervous system activity. And this is essentially how one of the major mechanisms of atropine results in increase in heart rate. Now, the other subtype, the nicotinic acetylcholine receptor, as you can see, when it gets activated, is the calcium and sodium that enter the cell. So it results in depolarization of the cell and influx of calcium, which is the major signaling molecule. So lots of things happen stimulatory when it gets activated. So nicotinic receptors, you can see them in the synaptic junction of both the sympathetic and parasympathetic nervous system ganglia. Acetylcholine, or the agonists like nicotine, they excite the postganglionic fibers of both systems. So when you give low doses of nicotine, you get stimulation of the autonomic nervous system of the ganglia. But if you give high doses, it actually has the opposite effect. So it acts as if it's antagonizing it. So a little bit of smoking makes everything excited, but when you smoke too much, you pass out. People usually don't get there. So when this happens, it produces hypertension, tachycardia, by release of epi and norepinephrine from the adrenal medulla. Remember that the adrenal medulla, the presynaptic nerve terminals synapse with adrenal medulla directly, and the neurotransmitter there is acetylcholine. Alright, so let's change some gears. Talked about the muscarinic receptor, the cholinergic receptor. Let's talk about the adrenergic receptors now. The adrenergic receptors are called adrenergic or noradrenergic, and this is based on if they respond to epinephrine or adrenaline or norepinephrine. So if they're stimulated primarily by epinephrine, adrenergic. If it's norepinephrine, noradrenergic. There's also the dopamine receptor, but the role of the dopaminergic receptor is very controversial because there is no peripheral dopaminergic neuron, but the receptors are there. Adrenergic receptors are found in two primary loci in the sympathetic neuroaffective junction. They can be presynaptic or they can be postsynaptic. There's also the extrasynaptic sites, and the roles is not very well elucidated yet. So here again, try not to get confused by the pre-post ganglia and pre and post synaptic membranes that we talk about. So again, this slide is paramount to keep you on track. So here we're talking about the post-ganglionic sympathetic nerve terminal. So remember, here's the post-ganglionic, you see it in the big arrow. And this is the junction of the nerve and the effector organ. The presynaptic membrane is on top, you see it. And here you see that alpha-2 receptor there. You have the postsynaptic membrane, and here you see the alpha-2 receptor again. So alpha-adrenergic receptors. Two major subtypes, the alpha-1 and alpha-2. Alpha-1 is classified into this class because it's antagonized by yohimbine. Alpha-2 antagonized by prazosin. Alpha-1 receptors are found in smooth muscles of everywhere, essentially. The peripheral vessels, coronary artery, skin, uterus, intestinal mucosa, splanchnic bed, etc. They're everywhere. When the alpha-1 receptors essentially serve as postsynaptic activators of the vascular and intestinal smooth muscle, also the endocrine glands. When you activate them, they either decrease or increase the tone depending on the effector organ. The response in resistance and capacitance vessel is constriction. So when you give alpha-1 receptor agonist, like phenylephrine, your resistance goes up in the regular blood vessels. But if they go to the intestinal tract, it results in relaxation, so the opposite effect. There's also postjunctional alpha-1 receptors in the heart, which has a positive inotropic effect on cardiac tissue. So, we say phenylephrine doesn't increase the inotropy, but if you give a high enough dose, especially in an isolated cardiac muscle in the lab, it will increase inotropy. But for book answer, it does not, even though it's true. So, when you give prazosin or phentolamine, it antagonizes the alpha-1 receptor. And they actually have a pretty significant antiarrhythmic activity. They prevent catecholamine-induced ventricular arrhythmia. And this is because there is no alpha-1 receptor presynaptically. But there is alpha-2 receptors presynaptically. They're also present postsynaptically. And again, this is the postganglionic neuron. When you stimulate the presynaptic alpha-2 receptor, it inhibits norepinephrine release. So the negative feedback, that's the regulation of the release of norepinephrine, one part of the regulation. So when you stimulate the presynaptic alpha-2, you reduce the release of norepinephrine. So the central effects are primarily related to reduction in sympathetic outflow, as well as enhancing the parasympathetic outflow. So this results in decreased systemic vascular resistance, cardiac output, inotropy, and heart rate. The presynaptic peripheral alpha-2 effects are also very similar. And norepinephrine release is inhibited in postganglionic neurons. Again, presynaptic alpha-2 in the postganglionic cells. But when you stimulate the postganglionic alpha-2 receptor, very similar to alpha-1 postsynaptic receptor, you also get vasoconstriction. Norepinephrine acts on both alpha-1 alpha-2 receptors. So, when you give norepinephrine, it activates smooth muscle vasoconstriction via both alpha-1 and alpha-2 receptors. So this is the postsynaptic action of the norepinephrine. But it doesn't work only on postsynaptic receptor, right? So it works on the presynaptic too. So when norepinephrine binds to the presynaptic alpha-2 receptor, it inhibits its own release. And this is part of the feedback that's important in its regulation.